Hi, my name is Steve Rosenberg, and I'm moderating the last panel of Where Do We Go From Here? And I want to introduce my fellow panelists. To my left is Dr. Louis Baxter. He is the current President and Executive Medical Director of the Professional Assistance Program of New Jersey, as well as being the Medical Director of the Division of Mental Health and Addiction Services for the New Jersey Department of Health and Human Services. He's also the immediate past president of the American Society of Addiction Medicine. To his left is Dr. Lucy Perez, the Director and Chief Executive Officer of the CAVE Institute. Previously, Dr. Perez was the Associate Director of the Center for Substance Abuse Prevention at SAMHSA. She's a leading authority on substance abuse and HIV prevention, and I think that Dr. Baxter and Dr. Perez might have known each other from medical school, I'm told.
Yes, we graduated 12 years ago.
That's great. And of course, I don't need to introduce Gary, our co-host of this meeting. I want to start by using three words that we haven't heard here yet today, which to me, I don't think you can talk about the racial disparities in criminal justice without talking about the war on drugs. And I want to put that front and center for a minute and sort of say, well, you know, particularly Dr. Baxter in your ASAM capacity, we're in a very different world in understanding how to treat addictions when we were back when the, quote, war on drugs started. I think that just about everybody in this room would agree that why we have the racial disparities we do in the criminal justice system is directly attributable to the war on drugs, and whether you want to talk about the differential sentencing for crack and cocaine or whatever history you want to talk about, it's sort of out front. So the question I want to ask, and you alluded to it, which is why I asked you to wait on 10 minutes, is there anything in health reform that will let us think differently about how the war on drugs has resulted in the disparities in the criminal justice system?
Yes. As I had started to say, first of all, I want to thank you for bringing this together for us today. I've been involved in many of these discussions for many years, and this is the first time that I've been involved in a meeting like this where we've had so many different stakeholders. And never before have we seriously addressed the issue of health disparities in criminal justice. So I'm very thrilled, and I want to applaud you for that right up front. The war on drugs was born out of the concept that drug addiction and drug abuse was willful misconduct, and that people were being bad, and therefore we needed to wage this war to make people act better. What we've learned, though, is that all of the resources that were poured into the war was on the side of punishment and very little on the side of treatment. And certainly any of you that have been involved with people who have substance use disorders, if you close down a source over here, they'll go find one over there. With the information that we've been fortunate to get from NIDA and some of the other agencies, NIAAA, I hope that's not me, NIAAA and SAMHSA, we know that addictive disorders are actual real medical conditions. They're chronic medical disorders. Just like any other chronic medical disease, you have early stages, middle stages, late stages. You can point directly to physiologic changes, and we certainly have that now when we're talking about addictions. So we know that it's a brain disease. There are end organ damages, liver, kidneys, what have you. And so I think that since the end of the Clinton administration, I've been fortunate to be a consultant with ONDCP since Clinton's administration. We have seen that there's been a focus in terms of the resources. It has has gone from punishment and more towards treatment. Since President Bush's last term, and certainly through President Obama's first term, we have put more efforts into the treatment aspect of the conflict with drugs.
Do you think that there's anything in health reform that lets us think about it as a tool to end the criminal justice disparities that have resulted out of the war on drugs?
Yes, basically because in the drafting of the ACA, those of us that were involved with ONDCP, we pressed for certain language. One is that substance use disorders be considered as a chronic medical illness, and therefore that it would be addressed by health insurers as such, and not as willful misconduct. I think that when we look at some of the other consequences of how the war on drugs disproportionately enslaved or imprisoned minorities, there were disparities about even the actual sentencing guidelines. If you had powder, you got an easier way to a go. If you had crack, you had a harder way to a go. Now, some of those sentencing guidelines have not been changed, but they're looking at them. And people are making efforts, I think, in terms of trying to ameliorate what I think was improper in the first place.
Dr. Perez.
And I'd like to, and I don't mean that it is everything, but it is an elephant that's in the room, and that's the issue surrounding the disparity as it related to the war on drugs. It was clearly racial.
Yeah.
And its impact has the impact that we're now seeing in the criminal justice system. Just as many of the provisions of the Affordable Care Act, or when it wasn't politically correct, what was called Obamacare. And so when we look at that, we have to also bring into the conversation the issue of racism and institutional racism. And as we bring that in, usually it's something, whenever I bring up the big R, it either gives you a glassed over feeling, or people begin to say, oh, it comes up again. But, if it quacks and it waddles, what is it?
It's a duck.
It's a duck. So, it's something that we have got to begin, be real. Mm-hmm. I never intended, it wasn't my intention to ever become very involved in substance abuse and HIV disease. But when I graduated just a couple years,
12 years ago, right?
That's what was going on in New York.
Right.
And that's what had to happen. It was in 1983 when I had my first patient with AIDS. 1983. There are people who weren't even born in 1983 in this room. And so we have to begin. We've been talking about falling off the cliff, the financial cliff. There is a cliff that we have to deal with in this country that we refuse to deal with, and that is the equal value of everybody. And that is part of this conversation.
I appreciate that. That's why I hadn't heard anybody up until now mention these three words, war on drugs. So I thought it was incumbent on myself. Gary?
You know, I was listening very carefully. I have the opportunity to participate in a lot of conversations about health disparities. And I'm not going to suggest equivalency, but just to give you a feel for the conversation. So in Medicaid, if you're obese, you can't get reimbursed for services if you're obese. If you are a smoker in Medicaid, there's no reimbursement for therapies for smoking. A lot of what we have, and on the race issue, we look at people who are obese and say that's their fault. We find permission in a lot of different ways to exclude people from the healthcare system. And part of it is that we have persuaded ourselves that healthcare is a rare commodity, that it's a scarce commodity that has to be rationed. Lots and lots of conversations about rationing healthcare. So when you come to the rationing of healthcare, what you want to do is get permission to exclude some people. You want to exclude them by race, you want to exclude them by weight, you want to exclude them by behavior, whatever it is. And so it becomes a really important collective conversation, because what you have to appreciate, where we're going with healthcare in this medical revolution, is that we have community choices now. This is not like the 1950s in which, you know, somebody comes down with a disorder and we have no technology for them. You know, you go into the hospital and it's a bedpan and a sponge. I mean, that was the technology then. That's not what we're talking about now. We're talking about we have the choice to decide where we allocate our resources and who gets it and who doesn't get it. So a lot of this conversation, be it about substance abuse or race or weight or behavior, is really about the search for permission to excuse ourselves from accepting responsibility that we have to make some very, very fundamental choices about healthcare in this country. And I would argue, and this is my own personal perspective, and I realize it's fundamentally different, but I live by the philosophy that you fight for life every day. You don't excuse yourself, you don't give yourself permission, you don't look at that person and say, but for your behavior, you wouldn't be there. Right? Because we all do that. We all do that. And so I think that's really the struggle at hand right now. And then we come to the policy decision. Once we set our values, then we can have the policy decision about what we want to do.
So that feeds right back to what you were saying a few minutes ago, Dr. Baxter, that as we start seeing that substance use is not an act of negative willfulness, but is in fact a clinical disease, then the question of where we make investments and what kind of investments and what kind of diseases we choose to treat very much involve these issues around racial disparities. And I just want to make sure that we're all being clear with each other and with all of you about this relationship between who's in jail, the war on poverty, I'm sorry, the war on drugs, right? I understand, that was a little slip. There's a little relationship there, right? Who's in jail, the war on drugs, and the choices we make about what health conditions we treat and we don't treat. And I think part of where the morbidity data on people in corrections is so important is it speaks to the outcome of decisions we make about not providing community-based services, particularly for behavioral health disorders, for not identifying folks young. Again, my experience, and go to jail, talk to a dude. When's the last time you went to a doctor before you were in here? My junior high school sports physical, okay? And those are choices that we're making about our investments. And so as we envision the future, I think what you're hearing Dr. Puckrain say, what you're hearing us say is we have to rethink how we make those investments, because we've ended up with a very expensive criminal justice system that doesn't, in fact, protect public safety. And I think that's where we all get hung up. Dr. Baxter.
Well, I'm thanking you again because you know what, you actually made us look at the elephant in the room, and I have always tried to steer away from looking at potential things that are in the dark or in the shadows, but as Dr. Perez has said, and as Steve has led us to, we have to acknowledge that racism does play a difference in the health disparity. I can tell you now that you got me open, okay, that I remember when I was in my training in medical school, that when we took care of ward patients, which were mostly minorities, in Philadelphia was primarily African American and Puerto Rican, I could see that we weren't allowed to spend as much time with those patients. And in fact, we were many times encouraged not to get too involved and just move on to the other patients, which happened to be the ones that were not minority and that in fact were good payers because you could order a lot of stuff on them. So, as I try to grapple with the problems that we're facing today, I try not to let that get out in the forefront because that's not useful to me. But I have to say that we cannot ignore that because it is a part of what in fact does happen. With the Affordable Care Act, though, although it seems cruel to some people that you mandate everybody to have insurance, that does in fact help put more people on a better footing in terms of getting their medical issues addressed. I think that one of the last bastions of Spankum is the criminal justice system. And after all, that's understandable because that's what it was designed to do, is to punish. It wasn't designed to treat people nicely. It wasn't designed to take care of medical needs. But where we find ourselves that we have such a huge population of individuals, minorities in jail because of undiagnosed or diagnosed and untreated or not appropriately treated chronic medical illnesses, jails and the criminal justice system now finds themselves in a position where they actually need to get into this business. And getting into it will do a lot in terms of saving our economy and all of the resources. You all read many accounts, but the one that I remember is that every dollar spent on addiction treatment returns $7 back to the economy. And when we treat people with these chronic medical illnesses, we return people to their families. We return people to the workforce. The legislators like to hear that now we got more people to tax because they're working. But we do great benefits when we take the opportunity to address these issues and get people the appropriate treatment that they need. And we're finding them, a lot of them, in the criminal justice system.
Dr. Perez.
One of the things that came up in one of the other panels, and it's talking about how looking at our history so that we don't continually repeat the same thing. You know, the Lord says that there's nothing new under the sun. But we, you know, the Israelites eventually came out of the wilderness. You know, it took 40 years for an 11-day trip, but they eventually came out of the wilderness. It's getting to that time as it relates to us right now. You know, we're seeing, by God's grace, You know, I have a 33-year-old son that I had when I was 2. And I'm sure you read about it. And I also have a 7-year-old son. And and they're both black. You know, so think of those odds. You know, I can remember taking my 20-year-old son to our pastor and asking for special prayer, because that was a passage for me. He had made it to 21 and he was still alive. You know, my son, that son, has one friend of the 5 that he used to hang out with, one that is still alive. 1. 2 of which went out with a diagnosis of schizophrenia. 1 jumped off of a bridge and got hit by a 18, you know, the big ones. What is that, 18 wheels?
Yeah.
18-wheeler. And my oldest friend, who was his mother, watched them pick up parts of his body off of a highway. The only outreach that she could get for him for health care was the police department, because that's how we bring in people who are mentally ill and are violent at that time. And the other friend, who is presently incarcerated and has been incarcerated for most of his adult life, and he's 33. We got to come out of the wilderness, and we have got to have the will to do. We have got to have the will to do. I know when we talked about HIV disease, I would always say that's got to be the conversation that you have at the Thanksgiving table. It has got to be our conversation this holiday season with our families. You'd be surprised at the prejudices that exist within our own families around people who are involved in the criminal justice system. You know, as quiet as it's kept, everybody, we're webcasting, right? Maybe I should keep this a secret. Okay. You know, when we really think about it, you know, we're talking about our future. We are really talking about our future and how we want history to remember this generation.
Mm-hmm. Gary?
You know, I remain so optimistic about where the journey that this country is on, that you know, when I look at the challenges that confront us right now, and if we can manage to maneuver our way through these passages, that we will come out the other side really a profoundly stronger democracy, as well as really a healthcare system that can provide quality care for a diverse population. I was listening intently to the last panel and the discussion around reimbursement for health care. There is this sentiment abroad in our country that health care is just a cost, that it's not a value proposition, that it's an expense item. And there's this feeling that if we're only those who can afford it should have it, and we treat it as it's an award for being an entrepreneur, for being an athlete, for being an actor or an entertainer, but it's not anything that is that the society is committed to making available to everyone, and even because it is this rare, precious commodity. We have to rethink that, and I think part of what's happening in this country, because minority populations are starting to get a voice. Quite honestly, I didn't think they were going to have a voice of 2016. Obama's election it blew me away a little bit, because anybody who's been watching the demographics knew 2016 was kind of the fault line in terms of minorities bringing a voice into the body politic. I remember there was in Massachusetts in 1670, there was this whole conversation about whether African Americans could vote. It was early Massachusetts. And I remember the sentence very well. We can't embody with them. Embody with them. They can't be part of the body politic. And here it is now, we are embodying in a way in which a few would have ever imagined in this country. Those new voices are going to have impact on healthcare. They're going to bring experiences that they want rectified. And the society is going to be deeply challenged by that, because some are going to see that as redistribution, as providing care to the undeserved, transforming the social compact. Those are really deep and fundamental conversations. And that's why you see all this litigation flying all over. It becomes a constitutional issue about whether somebody who has diabetes should have a medication. That's a conversation. But I think just by the profound needs that are within this new and growing community, this emerging majority, we're going to see dramatic and very, very important changes, so that the stories that Lucy just told are not really, they're asymmetrical in the future. That's where we're going. We want those to be asymmetrical events. And so I'm excited. You know, I realize that it's a lot of work. It's a lot of work. It's a lot of reframing the conversation. It's a lot of persuasion about helping the American people understand that, number one, it's your money. Number two, you should invest it wisely. Number three, when we come out the other side, we will have eliminated challenges that the next generation won't have to face. I think those are profound investments.
So this morning, I started talking about, just over 2 years ago, Cochs started a conversation in this very room about the interaction between health reform and criminal justice. And we wanted to have this conversation today because we wanted to look at that conversation from a different lens, from the lens of racial disparities, because we didn't want to shy away from the racial disparities in the criminal justice system, the racial disparities that Gary pointed out this morning, I guess that was, in the healthcare system, and the interrelationship between them and the potential. And I think the key word here is the potential for the Affordable Care Act, if not to cure them, to at least make a dent and rectify and bend that curve. And I want to thank you all for participating and sharing in that, and ask you any questions. Do you want to ask the panelists while we have them?
Hello. Thank you. First, I've been here for a while. And
Elwood, could you identify
Oh,
yourself?
I'm sorry. I'm Elwood York, and I'm on the Cochs board. And for a while, I was like some of the other people. I was trying to figure out why I was here. Now I know for sure. But I want to say something. There's been a lot of questions about what's the difference between a jail and a prison. Okay, let me help you with that piece. A jail is a place that you go to be detained prior to being sentenced. It is a detention facility. If you are sentenced and you get a sentence of a year or less, 364 days, you go to a jail. Anything above 365 days, you go to a prison. So when you look at health disparities, you got a short window in a jail because you'd have to be a real idiot to get all 365 days. You're only going to get about 6 months, 7 months, and a lot of that's going to be whittled down because time served while you were waiting to go to trial. So as you talk about health disparities, these people are coming right back home. They're going to be off the reservation for 3 or 4 months, and then they're going to be dumped right back in the population. So I wanted to say that for everybody who is confused about jail and prison. Second, corrections or jails started out as houses of correction. They weren't initially intended to be punitive. You went there to learn a vocation or a skill or to do something so you could contribute to society. And that part of it has been lost. So we need to get back into putting correction into corrections. The last thing for my colleagues of color, we need to be more demanding of the services that our people get, okay? For my colleagues of the majority, you need to help us speak up. And let me say why. I've worked in both situations. I've worked in a situation where 98% of the people were black and they were locked up. That's D.C. I worked in Monroe County where I go to the jail and damn, everybody's white that's locked up. I was like freaked out. I went to court on the first appearance docket and everybody in handcuffs was white. I'm like, oh, this must be discrimination. They must have the brothers in the back. Okay, and the reason I say we need to speak up is because, I'll give you an example. Cedric, you got drug court in C. Sosa. If you told them that you wanted to have all of your drug court participants take Bikram yoga and get acupuncture, they put you on a burning boat and float you down the Potomac. But in Key West, I brought that up as a suggestion, and the judge was like, yes, let's try it. And the judge, who's a woman of the majority, said, Elwood, I'm not going to make you bring it up because they might say you're trying to pull the race card. I'll bring it up. You just follow me into the fight. Don't leave me out there hanging. So, Mr. Duarte, I get it. You got to get the prosecutor, you got to get the court, but we need to set a different baseline for what's acceptable. If you see that someone's getting poor treatment, the best uses are not being practiced, somebody needs to raise their hand and say, hey, hold up, stop. And we need to stop being too afraid to be politically incorrect. We're talking about health care. We're not talking about something social. We're talking about something we can fix on most situations. So I just wanted to clear those things up, and I'll open that back up to your discussion, but I just wanted to make sure we got jails and prisons straight, if nothing else. So thank you.
Thank you, Elwood. I think there's another hand up on the other side.
Hi, Tracy Gardner from Legal Action Center. And I actually have a question, because you say questions for the panel and then I can speechify. And I've especially enjoyed this summary and really do appreciate the mention, the driver of our drug policy that plays intrinsically into why we're talking about health disparities among racial ethnic communities. I was talking to Mr. Rosenberg earlier about it. Just for those of us who've been working in HIV and looking at health disparities, the t-shirt should say, it's prison stupid, it's jail stupid. That is the core of when we make our communities unhealthy, what is going on. I guess in sitting here and listening, and this is not to be fussy about the name Cochs, but where did we come from with this idea of correctional health? Unless we're talking about, at least in New York, 22,000 people are coming home a year. Only the bads stay forever in prison. So when did we get to this place of correctional health as separate, distinct, and totally apart from community health? And why is there, why are we here? Why are we coming in with the quote unquote corrections, criminal justice population late into the game as the healthcare landscape is being changed? In New York, the correctional system, the state correctional system, has a healthcare system as big as some large states. Right. But it's separate and apart jurisdictionally, oversight, and program from the Department of Health. Yeah. I had a commissioner of the State Department of Health who had experience in providing correctional health say that correctional health was not going to be within the scope of his department in his tenure. Why is it separate? Why do we not understand that the churn and the flow and the connection, and that when you're sick inside and you go home, the community's going to be sick? I heard the issue earlier about the ministers who were concerned about the guys coming home who were infecting their presumably female parishioners. And it's like they went with the STD. They're coming home to a community that's saturated with STDs, as well as the other health disparities. Talking about the unmentionables, sex, drug use. If we don't talk about it, well, we've seen where that gets us. But I'd like possibly, especially Dr. Baxter, to talk about what is correctional health and why is it separate and apart from our thinking about what we need to do in terms of healthcare.
Yes. You already answered that, but I'll say what you have said. Yes, seriously, because it really should not be any different, but it has evolved, and when we're looking at health disparities and we're looking at trying to get people well, whether it's diabetes, HIV, substance use disorder, when you have people that are captive, as we were just educated, for 6 months, almost a year, that's a great opportunity to diagnose these problems and to get people started into a treatment. As a matter of fact, when we're talking substance use disorder, if you have somebody that you can put into a treatment for a year, you've got pretty good outcomes. People that have a full treatment experience, detox, rehabilitation, counseling, and then aftercare, at the end of 1 year, it's greater than 77% success rate. So there's a tremendous opportunity, but it has become different because for many years when people went into the criminal justice system, into a jail, they weren't given the types of care that they should have. People did not think that was something that they deserved. You're in jail and you're here to get punished, not to get treatment. And that's fortunately changing. And we have a great opportunity to improve that whole thought process when people enter into criminal justice.
And I want to add a PS to that before we go on. Here's my I want to add a PS to that before we go on to the next question. Jails historically have been places of segregation. Devil's Island, the continent of Australia, the state of Georgia, Alcatraz, Rikers Island, that we have conceptually understood jails to be islands where we segregated folks from the rest of the population. So maybe the racial disparities we see in jails today aren't that surprising if we go back to the original function of the jail. We have time for one more question. Wait, let them give you a mic first.
I'm a professor at the University of Washington in Seattle, and I want to thank all of this panel and all the panelists today, and the organizations for sponsoring this, and the Robert Wood Johnson Foundation, I mean, who's been a leader in healthcare policy and research. And I want to say that I really appreciate the optimism, I think, that has been shared here today about the potential for the Affordable Care Act to meet the needs of a population that I think has been largely ignored by most other institutions in this country. The educational system has failed many of America's inmates and those with contact with the criminal justice system. The labor market has failed them. Many other institutions. And I guess one of the, I have two specific questions, but I think it's really interesting that here we are after 35 years of growth in the criminal justice system, and we've now had 4 years of stability. And I think those 4 years of stability have not been induced by some great moral shift in society, but they've been induced by legal challenges. The Plata case in California, it's no surprise that California is a leader in criminal justice shifts. They have been mandated to do so. And also the fiscal crisis, which has forced states to think really hard about how to spend limited resources. And I think one other reason we're thinking hard about this collectively is that there are 2.3 million people in prison or jail, and they have 2.7 million children. And that's something that I think we are dealing with every day in schools, in healthcare facilities, and in a wide range of other settings. And I think that it's fantastic that we're thinking about this, and I have two questions. The first is, how do we keep the healthcare settings or healthcare settings from becoming another institution of surveillance? And that is that if people who have contact with the criminal justice system have medical needs, they want to use providers, but the criminal justice authorities know that they might do that. And that may be just another place, just another site to surveil. And how do we keep that from happening? How do we protect those who are most vulnerable? And the second is, I guess I want to ask the question about if sort of in an ideal world, when would we intervene? And that is, in my view, I think when we're looking at reentry, we're already too late. And so, one of the things that I found most optimistic today was thinking about, targeting youth through the juvenile justice system, or even before that, and coupling medical needs with the whole host of other social services that many of these children need. And so those are my two questions for the whole panel.
One of the things that you said, especially, we did it at SAMHSA. We call it Pregnant and Postpartum Women and Infants Program. And what we were looking at was the difference between primary and secondary prevention. And the primary prevention was occurring with the mother who was addicted, and the prevention was for her child. So not only were we talking about the mother with the secondary prevention, but the primary prevention for the child. When I was chief of adolescent medicine in Brooklyn, and I just took, I think we talked about it at lunch, took a little side gig working at Ella McQueen, which was maximum detention for adolescents in New York City. When I went in, I thought it was going to be an easy job, just signing a couple charts behind a PA, and I heard the cash was nice. But the issue became that the provider for this detention center actually never touched any of the residents there. Whatever. And as I was signing and, looking at the cases, it wasn't even standard of care that these young people were having. The other issue was that all of the young, not all of, let's say 80% of the young people at Ella McQueen had in one way or another come through the Brooklyn Hospital medical system, either either of our locations at the time, and that was a point for us to have intervened. And my issue was, why didn't we meet it at that point? Why wasn't there an intervention? And a lot of what we've heard about this increased interest is around money. Okay, even though it's a little bump, it's a bump. And there are people, and it's important that we make a distinction between indigenous, the people who are in it and in it for the long haul, and what we used to call the carpetbaggers, who are just sliding in and sliding out. And the states that have a more a different type of emphasis on their responsibility for a particular population. So when I take all of that into consideration, and some experiences that I've had in the past, the surveillance issue is minimal to non-existent. I don't think that should be an issue that we should veer away from. The openness and the exposure of people who are involved in the criminal justice system is already out there. And to have a concern like we used to have around confidentiality and partner notification is not something that should distract us from what we're doing. And the other issue that you talked about was the issue of juvenile justice. Again, we're talking about another pot of money. And the money that leads into that, which is foster care. So we get down to mingling the dollars when we're dealing with them, and a provision of the Affordable Care Act is the medical home, and how we can be innovative with that conceptual framework when the vast majority of the physicians of, let's say, the National Medical Association are either solo or small group providers. And if they're indigenous to the community, that's even more so their history. So we've got to do what I think that we heard about from the previous panel, what managed care was able to do. And managed care was able to capitate, get the resources up front, coordinate their care, and dispense it. That's a completely different conversation that we're presently having as it relates to the Affordable Care Act, because it's so revolutionary.
Absolutely. Yes, and I can't agree with you more, because we actually went through that. I'll be honest now, when I first finished my training, it was basically fee for service. And then managed care came in and they said, hey, we're going to give you $2,400 bucks a month just to manage these people. And guess what? We took it and we did a good job. And now with the Affordable Care Act rolling out, and with this a patient-centered medical home concept, primary care physicians are going to have to be able to screen for addiction, be able to screen for mental health. We don't have enough physicians as it is to deal with the people that we have. We're going to have more. So physician and provider time has become more efficient. And I think that I was giving the other panelists a hard time, but I understand what he's talking about. And so, but we need to reimburse better to those primary care individuals that are going to be taking on, patient-centered, home type of activities. So, we've got tremendous potential, and a lot of possibilities with the Affordable Care Act, but the details is in the devil. I started to say that the devil's trying to mess it up, but you know, once that you have you know, laws, the trick comes in when you start writing the regulations, and that's why we have to continue to be vigilant.
You know, first I want to make sure I thank Steve and Mike for a tremendous conference, and their staff. Julie back there has done really fantastic job. I just want to pause on the privacy issue, because it affects not just the incarcerated population, but it is sort of one of the challenges of healthcare and access to healthcare data. As anyone would have gotten from my conversation today, I live in healthcare data, and one of the things I've come to appreciate about being able to access that data, be it for incarcerated populations, and there's actually a census that the federal government does in terms of health status of prison populations that I've been through and looked up hepatitis C to that population, et cetera. So it's important data. The future in healthcare is about big data. It's about being able to look at data and anticipate where you want to be. Where we want to be is we want to anticipate the event before it happens. We don't want to play baseball where we're swinging after the ball went by. That's not the game we want to play. The game we want to play is we can anticipate it because we can see it, because guess what? It's happened before just that way. And so in order to be able to do that, you're going to have to be able to access data. And I think there's a lot of issues from even clinical trials in researching incarcerated populations. They have a unique set of experiences that we need to know about and follow and understand. So there's an important conversation to be had there. I'm ever amazed that Americans go on Facebook and put God knows what on Facebook, and you ask them if they've got diabetes, and oh my God, I think it's a really important conversation that has to be had, but one way or another, however we do it, access to that information is going to be important.
One question, real quick. We got to get you a mic, Matt. Thanks.
Real quick, this has been fantastic, and I always am concerned about communication and messaging. So my question is, what's a mechanism that is in place or could be put in place so people like me who doesn't move around in your world can have access to this wonderful information so I can bring it to what I'm doing to make the connections?
I'll answer that.
Good.
And give me a minute, because I want to just say my thank yous first, and then I'll get to you. First, I want to thank you, Gary, for all of your help and your staff's help in putting this together. I think I can't tell you how many folks came up to me this morning after your presentation and said, wow, that was great. I need to thank you, Mike, and Nan for putting this together. Nan Torrey is the orchestrator of all this. It makes the trains run on time. And my staff, Jabe Zeno, Matt McKelly, Julia Kaiser for all of your work, Dave Horowitz for putting the travel together, Nancy Barron, the Robert Wood Johnson Foundation, who keeps this going, and Elwood and Julia for the board. And thank you. You have evaluation forms in your packet that I want to ask you to make sure you leave. Now I can answer your question that I've done my housekeeping. We record these programs, and this will be available on our website. Where's Ben Butler? In a couple of days? Okay, within a week or 10 days, this will be available on our website for viewing, so anyone in your agency can actually watch the entire day. In addition, where's Mary Darby? Mary, in back there, is doing proceedings of this conference. We will be disseminating them to everyone who was part of this. Why your evaluations become important is they help us continue the conversation. As I said, this is the third invitational-only conference that we've had in this room. God willing, we would hope to have more. And it's our goal to continue this conversation and keep you all in touch with each other. So I hope that answers your question in terms of the role of coaches and the Cochs website in doing that and keeping that together. And as I mentioned, we will be disseminating the proceedings of this once Mary's written them, which I think will be a couple of weeks. So again, I want to say thank you again. Thank you, Mike. Thank you, Nan. Thank you, panelists. Please make sure you fill out your evaluations, and everybody travel safely. Thanks very much.